All right. So we have five panelists, Dr. Amol, Dr. Sainath, Dr. Pradeep, and Dr. Naresh, I think, is joining us in a while, and Dr. Vidya. Can I ask everyone to turn on their video so that I can direct a communication to them? So today, in next 20-25 minutes, we are going to just discuss one case, and this is the solitary case that we want to discuss. And during the entire treatment line for this patient, we want to have multiple tumor board discussions. So quickly, this patient is a 54 male, presented with anemia last 3 months and a significant weight loss. He has no comorbidities and there is no significant family history. Colonoscopy showed a sigmoid mass and the biopsy was moderately differentiated adenocarcinoma. It was non-mucinous because mucin was less than 10%. Ultrasound abdomen was done outside, which showed extensive bilateral bilobar liver lesions, and CA was elevated 700 plus. And a CT scan had, this was the CT scan. You could see both lobes were studded with metastasis. So if I can come to Dr. Amol. So Dr. Amol, hi, good morning. So in this case, what are your thoughts on further staging with either PET scan or an MRI of the liver? What are your thoughts on that? Or the CT scan more than enough?
Yeah, well, Dr. Viraj, see, basically, he is a clear-cut case of a metastatic sigmoid malignancy, and as you can see, there are multiple bilobar mets, so there's no point doing a MRI for the liver lesion.
Right.
Yes, I would tend to do, considering current scenario, I would tend to do a PET CT scan, but I guess even if we don't do that PET CT scan, CT abdomen is good enough for me to, continue with the treatment of this patient.
Right. So, which scenario would you want to do an MRI of the liver in a metastatic colon cancer?
Yeah, so definitely, if there is a oligometastatic or where there is a single liver lesion or, in a same lobe, if there are even two lesions, then I would consider doing a MRI liver so that, I could still go ahead with a curative intent. Now, this is a purely palliative intent. So doing, MRI liver is not going to help us by any way.
Excellent. Excellent. So, Dr. Sainath, if I can come to you, with the biopsy of mucinous, moderately differentiated adenocarcinoma, how would you proceed with molecular testing of this patient?
So ideally for most regularly what we do at clinic is do extended RAS testing, KRAS and NRAS testing, BRAF testing and MSI testing. Even though the left-sided tumors, the chances of having an MSI high tumor is high, it's a very small percentage. Around 2 to 3% would be probably MSI high sigmoid colon. But still, because we have a very good drug for MSI high patients, I would do even MSI testing for all the patients of any colon cancer, be it left-sided or right-sided. This is the bare minimum thing which we can do. And also HER2/neu testing is also recommended, even though the percentage of cases would be there. I would generally first do these tests, and depending upon the results of these tests, then think of doing an HER2/neu test.
And how would you do them? Like, would you do them by PCR or NGS?
So right now I've been doing it only by PCR method. So I haven't changed my practice to still NGS. So I do it by PCR method.
So do you see any benefit of doing NGS?
MSI testing, I think there is a significant difference. Sometimes you are likely to miss certain cases by PCR and better by NGS. But apart from that, I think for the RAS mutations and BRAF, I think it is decent. You still get a decent result with PCR. The only thing in cases where the tissue is an issue, probably, I think NGS fares better in identifying this. But colon cancers, especially when you have done a colonoscopy guided biopsy, generally we don't see that issues. But unlike in lung, where the tissue actually is very difficult to get the good amount of tissue, where you choose an NGS methodology.
Okay. So Dr. Vidya, are you here?
Yes, sir.
Hi. So Dr. Vidya, we do quite a lot of NGS work, and What is your thinking about doing NGS on day one? Like say this patient had NGS on the diagnosis with the foundation report. You think so? In particularly this case, the role of NGS, the NGS did not impact anything new compared to what Dr. Sainath would do in a PCR. But just wanted to tell the audience what are the benefits of NGS on day one. Can you elaborate on that?
Sure, sir. So definitely, when Dr. Sainath mentioned a couple of instances, that is the first thing, when there is a diffusion issue, that like when you have very limited, if you are doing a true cut biopsy of a relapse site and then you get very small amount of tissue, first you want to reconfirm its primary that has got the previous primary that has gone to the metastasis on IHC, and then subsequently you go and do the NGS, you have definitely very less tissue in hand. So in that scenario, NGS will be a very big value addition for the patient. In addition to this, NGS provides the most comprehensive solution to all the biomarkers which are actually required in a metastatic colorectal cancer workup in general. If you take starting with all RAS testing, KRAS, NRAS, and then BRAF, along with that HER2 amplification you can get, along with that you can also get the TMB and the MSI score. We have developed the MSI on NGS in our lab, and also Foundation One, and there are several other diagnostic tests in the market where MSI based on an NGS approach, which will include not just the mismatch repair genes, which we all know, the four genes, and in addition to that it would look for some other rarer genes in this group like MSH3, which is very rare, but we do have some anecdotal cases in our lab where there is a clear cut family history of Lynch syndrome. MMR IHC does not show a positive answer, and then a limited NGS panel never showed up with, if you look at only those four genes, you didn't pick up. Then you look at a much bigger set of genes, then it turned out that MSH3 termination was there in that patient, which
Sure.
wouldn't have been possible to pick it up if we did a step by step approach. I mean, time is gone. Time is being very precious. You get all the answers in one single assay. That is the big advantage. And added to that, in NGS, you can look at not just the DNA biomarkers, you can also look at the RNA based biomarkers like NTRK fusions, which although is a very very small proportion of CRC patients, but we can still give the benefit of doubt in those patients when all RAS is negative and then MSI is high, then there is a good chance that these patients could be positive for NTRK fusions.
Sure. Sure. No, that was an excellent summarization of that. So like, with NGS, I'm a proponent of NGS on day one. Usually I started doing that since more and more Indian companies are coming up with a cheaper test. So one of the few results which could alter your first line management is Ras amplifications. Now we look for Ras mutations, but about 2% of colorectal cancers can have Ras amplifications. And we know that these Ras amplifications have the same resistance to anti-EGFR as compared to what would you have with Ras mutations. So it's an important thing. We've been covering the HER2, that HER2 is not only to target HER2, but it's a negative predictive marker for use of anti-EGFR in first line. And what Dr. Vidya suggested is that there are fusions, although the percentage is very, very less than 1%. But if you were to do it in MSI high and all wild type, as you can see from MSKCC, almost 15% of MSI high, all RAS wild type would have some form of fusions, which could be potentially targetable later in future. One of the important thing Dr. Sainath suggested is that you would definitely do an MSI high, and we all jump out of the chair that, oh, this patient has MSI high, and we would treat them with IO. But we all have suffered that giving checkpoint blockade, even in MSI high, fail sometimes miserably. In fact, 30 to 40% of patients fail. And one of the reasons that was found to why these patients actually fail is that these are the patients who had low TMB. So low TMB MSI high is a very distinct cohort, which you would completely miss if you were to just do an IHC. And the only answer is with NGS. So if I have to do a immunotherapy first line MSI high, I have started doing TMB for those patients. And if it is low, I think these are the patients who are going to get early progression. So yeah, this was about NGS. And even the NCCN endorses that all these tests could be done as part of NGS panel, just like the lung cancer. All right, moving on. We have Dr. Koyala with us. Is he online?
I'm here, sir.
Yes, hi. So now this patient, we've got all RAS wild type, BRAF wild type, HER2 negative, MSS. Now I want you to take this discussion. How would you treat this patient with chemotherapy? First, can you elaborate on what kind of chemotherapy would you want to use? Single agent, a doublet, or a triplet?
So I missed the first slide while joining, sir, due to connection issues. So I just wanted to request you about the performance status and age, sir.
Excellent. 54-year-old PS0.
PS0. So in a patient with biomarker negative and excellent performance status, I would like to go ahead with, because the metastases are quite extensive, involving both the lobes of liver. So I might be willing to give FOLFOXIRI, sir.
FOLFOX.
Explaining.
So you use triplet in your practice quite often?
So in very few patients who are in their 30s, I have used in 3 patients only, not much of the data.
Great. Dr. Amol, what are your thoughts on that? You think, say, a doublet?
Well, I agree. I agree with him that I'll also go with double agent Folfox only, considering biomarker negative. So Folfox would be my choice also.
And what would be the partner for biological?
Depends on the RAS. If it's wild type, then I'll definitely go for anti-angiography.
It is all wild type.
All wild types. So definitely my choice would be cetuximab since it's a left-sided cancer. So cetuximab would be my first choice.
And cetuximab plus Folfox or cetuximab plus FOLFOXIRI?
Folfox, dual agent, not triple agent.
Dual
Folfox
agent.
with cetuximab.
And Dr. Pradeep, you said triple agent, triplet, FOLFOXIRI plus cetuximab or FOLFOXIRI plus BEV?
Because it is pan-RAS wild, provided there's no financial, definitely cetuximab.
So triplet plus cetuximab.
Yes, sir.
Okay. So that is very toxic. So I'm glad that we are all on same page. I typically use triplet for almost all patients. Of course, the modified version, not the full version, what Dr. Cremolini used. In fact, this is the only chemotherapy backbone which has consistently shown to improve the median PFS, which was 10 months for so many decades, almost 2 decades. And now we have shifted that PFS to 12 months, that is 1 year. And even the overall survival has been consistently improved as compared to doublet plus BEV. And like I agree with all my panelists that in left-sided colon, if you have all RAS wild type, the role of anti-EGFR is very well pronounced. It's far deeper response and far faster response, and also improvement in overall survival. Now, some important point Dr. Pradeep brought out was a triplet plus anti-EGFR. Dr. Pradeep, have you used a triplet plus anti-EGFR in practice? Like
No,
if you see cetuximab diarrhea, irinotecan diarrhea, 5-FU diarrhea, so 3 drugs causing diarrhea. What are your thoughts on using triplet plus anti-EGFR?
So in the patients where I have used triplet, it is because of the financial issues. So I used triplet for a good response instead of the targeted therapy. So I haven't used the combination of triplet plus EGFR. But provided an opportunity, I definitely wanted to use because recommendation do suggest.
You would want to try. Yes, so there are 2 good studies. The deeper one, which was presented just last ASCO, you could see this waterfall plot. Almost every patient is responding. People typically ask that, what would you use when patients progress on, when patient is refractory to a triplet? Well, this is a proof that almost 90% of patients will have some form of tumor shrinkage, especially when used on left side and all RAS wild type. But I must say that I have used in few patients, and the diarrhea is a major challenge. Diarrhea and mucositis is very, very bad. So I would very well reserve this combo for very, very young and motivated patients, and especially when I'm thinking about converting someone. In a purely palliative setting, I might step back, like in this case, we were sure that we are not going to convert this patient, so we went with doublet plus anti-EGFR, in this case panitumumab, for 8 rounds. So Dr. Amol, how many cycles do you use in first line? Dr. Amol, you there?
Yeah. Please pardon me. Yeah. What, Dr. Viraj?
How many cycles do you use in first line?
The Folfox one?
You said FOLFOX plus cetuximab.
Yeah.
You would do it for how many
Yeah.
cycles?
Yeah.
6 cycles, 8 cycles, 12 cycles,
Yeah.
until progression.
12 cycles. 12 cycles. Yeah.
And
12
then what
cycles.
would you do?
Yeah.
Like stop it or maintain it?
No, then I can basically I give 12 cycles Folfox and then with cetuximab, and then I will continue with the maintenance cetuximab. So I'm in favor of maintenance therapy.
Maintenance cetuximab alone.
Yeah.
Okay, Dr. Saina, what about you?
Yeah, I would have gone with panitumumab, given that the side effect profile is better than cetuximab. And typically, generally, the when I initially most of my patients I start with oxaliplatin based therapy, Folfox. So in these patients, typically the treatment is up to 3 to 4 months on an average 8 cycles, like 4 or 6 to 8 cycles, and do an assessment. And if they have the response, it's the toxicity and the tolerance of the patients which decides how many more cycles of oxaliplatin. I would rather generally switch over to avoid the long-term neurotoxicity and the quality of life issues. I would shift to a maintenance strategy. In this case, with panitumumab, like you have done it. So
alone or
stop oxaliplatin as soon as you get a good decent response, to avoid you can always use it back when the patient progresses or this thing.
Yes. Would you combine 5FU with panitumumab or just panitumumab alone, or just 5FU alone?
Generally depends upon the affordability, but if I start an EGFR, generally we do counsel for maintenance. So it is whatever data with panitumumab is there was with the combination. So the efficacy. So it definitely showed a benefit when you use a 5FU with panitumumab. But if the patient is not affording any any biological, I would rather switch to oral capecitabine and keep him on capecitabine maintenance. That would be more realistic way
right
to do.
So this is the reiterating what you said, that adding 5FU plus PMAB is better than continuing PMAB alone. And the latest study in last ASCO which said is 5FU better than doing 5FU plus PMAB, and PMAB plus 5FU is better than 5FU alone. Although overall survival is not improved, but of course PFS is improved, as in with any maintenance strategies that we use in colon cancer. Okay, Dr. Naresh, have you joined?
Yes, I'm here.
Hi. So, okay, so this patient had almost 5 months of maintenance therapy, and so 4 months of induction chemo and 5 months of maintenance. And after 9 months, patients had progression in the liver. At this point, how would you go about with this patient?
So I assume that the progression was a gross progression. And
gross progression.
Yeah, so if it's a gross progression in liver, then I would change the chemotherapy backbone from Folfox to Folfiri. Assuming his performance status is good and is fit for receiving any chemotherapy at this point of time, so I would change it to a second line Folfiri, and I would add an anti-VEGF, either a bevacizumab or zifaflibercept. I generally use bevacizumab in my practice because it's an older drug. More comfortable with it, and more data with that agent.
What about ramucirumab?
I have not used ramucirumab in the second line because of cost constraints. That's the important issue. We have data for ramucirumab in second line, but then I mean these are like basically their basic mechanism of action remains the same. And bevacizumab, ramucirumab, and zifaflibercept basically are all anti-VEGF. We don't have
So,
any comparative data, so I would still prefer bevacizumab because it is cost effective and we have more data on that.
correct. So your thoughts are completely in line with NCCN that if you are using anti-VEGF in subsequent lines, bevacizumab is preferred over aflibercept or ramucirumab. I completely get it. Dr. Vidya, are you still with us?
Yes, sir.
All right. So this patient, after 6 months, progressed on second line FOLFIRI plus BEV. And as all my medical oncologists would agree that third line is regorafenib or TAS-102, which are the approved treatment. But what are your thoughts on, bringing back the anti-EGFR by, super selecting these patients with liquid biopsy? What is the role of liquid biopsy in this scenario?
Essentially, KRAS mutations are something which they come during the onset of the disease, during the oncogenesis. They don't disappear so easily during the course of time. So this is like a torch. KRAS mutation driven colorectal cancer is like a torch you can carry through the course of treatment. In this patient, there is no biomarker that you can monitor on liquid biopsy because it is all RAS wild type. Having said that, if there is a disease progression upon addition of anti-EGFR therapy, we can still look for any new KRAS mutations that would have developed as a mechanism of resistance to anti-EGFR therapy. So that has to be done before you start off with the treatment. There is a visual disease progression, and then that comes out to be like a second baseline. So before starting of chemo, if there is a bulk disease present in the body, then we should go with their liquid biopsy. It's just one exploratory option, I would say, to see whether RAS has come back, or rather RAS is there due to the impact of anti-EGFR therapy. So that is what is the general biology that we understand from CRC. And
so you rightly suggested that KRAS is a mechanism of resistance. The clone starts developing over time on treatment with anti-EGFR. And as you can see, this is an excellent paper which suggested that even before the progression happened, the RAS clone started developing in the blood. And in this scenario, although it was all wild type, the clone started developing so early, within just 1 month, that this patient had a progressive disease. So based on this, there are two excellent proof of concept studies designed in colorectal cancer. One is by the Italian group, Dr. Cremolini, that patients has to have a 6 months of anti-EGFR treatment, followed by at least 4 months of non-anti-EGFR based treatment, and then you bring back the cetuximab again. And you could see that there are few patients who definitely respond again. And without any doubt, these were the patients who had liquid biopsy RAS wild type, as you can see the green lines. And the yellow lines are the RAS mutant clones, which has evolved over time. And these are the patients who did not respond to re-challenge of cetuximab. So this was an excellent proof of concept study called Cricket study. And last year we had a similar study with panitumumab called the Chronos study, that you had EGFR, then EGFR free, and then patients were mandated to have all these 4 markers negative: RAS, BRAF, EGFR, wild, ectodomain mutation, wild type on liquid biopsy. And then they were put on panitumumab, and you could see that 30% of patients had a response. Now in third line, we know regorafenib and TAS-102 is 1 or 2% response. This is far better improvement than that. Of course, but the major research is what are these red bars, that even though you super selected these patients, why these patients still progressed on anti-EGFR. So we still have more to learn rather than jump on this. But I have started doing this if patient is wild type, I always try and see whether I can reuse anti-EGFR in subsequent lines. Last point, I think, so we have just 1 or 2 minutes. Dr. Sainath, is there any role of immune checkpoint blockade in microsatellite stable colorectal cancer. Do you think, because like you said earlier in the day, that only 2 to 4% of total MCRC population is MSI high? What about other 95%? How are we going to exploit checkpoint blockade for them?
I think we need the other thing which you have rightly mentioned in the beginning about looking at the high tumor mutation burden. That is one of the predictive biomarker for immune checkpoint. Barring that, I don't think we have strong data enough to use it as a blanket therapy in MSS stable. So we need better predictive markers to actually use it in other population apart from tumor mutation burden and the MSI status. So I think awaiting that, we have to wait and watch.
Dr. Pradeep, any thoughts on that?
Yes, sir. So, in an interesting study was presented in ESMO 2020, also in MSS table, not only post multiple lines colon cancer, several other cancers which are resistant and all the standard lines have been adjusted. Particularly MSS status have been challenged with pembrolizumab plus lenvatinib. I didn't remember the name of the study, sir, but that has shown excellent result. Even in those, probably adding lenvatinib acts on the microenvironment and favorably acts converts the environment favorable to the checkpoint inhibitors to act. So I think that is one of the evolving therapy, pembro plus lenva, in not only in colon but several other cancers. So that is one thing which I look upon to.
Right. So you are absolutely right. I have a personal case of colorectal cancer who is doing excellently well on pembro plus lenvatinib, and this patient is MSS and very low TMB. So with that, but I completely agree with all my panelists that we need more data. This is a very, very evolving field, and soon we will catch up with our lung cancer colleagues. With that, thank you.